Welcome to the Aplastic Anemia and MDS International Foundation's webinar, Chronic Kidney Disease and PNH. Thank you for joining us. My name is Julie Powers, and I'm the Senior Director of Patient Advocacy at AAMDSIF, and I'll be moderating today's presentation. As we get started, we recognize the generosity of our sponsors for today's webinar, Apellis and Alexion, as well as our patients, families, caregivers, and friends who support the Foundation's educational programming. Due to the high volume of online traffic, there is a chance that you may lose your connection for today's session. If you're unable to log back in, please refer to the confirmation email that we sent, which includes a call-in and passcode. You'll be able to join us that way and listen to the webinar. The webinar is also being recorded, and we'll have it available on our website within 2 to 3 business days. We'll send you an email when it's ready. Immediately following today's presentation, there will be a Q&A session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, at the bottom of the window for the webinar, there is a little box that says Q&A. Just type in your question in the small text box window, and when you finish, press enter. We'll do our best to get to all questions. When you ask your questions, we ask that you do 2 things to help me manage the incoming questions. Please submit your whole question all at once, and please don't share any private health information in your question. Our speaker can't answer any specific question related to your health care. Today's speaker is Dr. Ramy Hanna, a clinical professor of medicine and nephrology at the University of California, Irvine, UCI-Health. He's a clinician-educator who focuses on researching all aspects of kidney disease. He earned his medical degree from UCSD School of Medicine and completed his residency and fellowship at Olive View, UCLA. Please join me in welcoming Dr. Hanna. Hi, Dr. Hanna.
How are you? Well, thank you for the kind introduction. Today we're going to be focusing on paroxysmal nocturnal hemoglobinuria, which is a rather rare disorder. I'm going to be presenting the material at a fairly sophisticated level, but we're going to go over the highlights so as to not lose the main message. That's very important for me to make sure that I educate you and then fully give you the information that will allow you to have a much more in-depth conversation with your physician. Keeping in mind also we're dealing with an advocacy group and obviously very many patients who have long experiences with the disease and may have some high level of familiarity. I've always been very well surprised and impressed by my patients, particularly after years of suffering or dealing or managing a disease. At any rate, today we are going to kick this off. I am doing this for the AAMDS Foundation, and today this is the time and date. Just want to make sure everybody here, if they have any questions, please feel free to follow Julie's protocol in order to make sure that we have an orderly transition of the slides and of the actual exchange of information. So I am a paid speaker and consultant for Alexion Pharmaceuticals. This is a necessary disclosure. I also work with Otsuka Pharmaceuticals on non-complement related issues. My main thrust and expertise is in complement-mediated diseases such as atypical hemolytic uremic syndrome and PNH to some degree, in conjunction with my hematology colleagues. I'm a principal investigator for a trial involving complement blockade at UC Irvine. So here is the map of the talk, and please excuse the little one, that is my beautiful baby daughter. But anyway, this is a map of the talk. So we're going to be talking first about pathophysiology and genetics in an introductory capacity, epidemiology and clinical presentation patterns. Many of you will recognize that this information because this is how you present it to your physician. Then will come diagnostics, which are very important because there's multiple layers of diagnostics that allow you to suspect the disease, confirm the disease, and then track treatment of the disease. Further, advanced genetics and pathology, I will go over in some depth to explain some of the more unusual features of PNH because it's quite a unique disorder. And then therapeutics, which I'm sure is what everybody's really excited about hearing today. And several of the sponsors, as we mentioned, are involved in developing cutting-edge therapeutics for PNH. And then we'll talk about some future pathways, which are things to look forward to in the development of new therapeutics for PNH. So the first slide we have here shows you a red blood cell, and actually you can see the pores that are formed by complement, the membrane attack complex. And you can see the formation of acanthocytes, which are what we sort of see macroscopically when we look, or not macroscopically, when we look under the light microscope, which is macroscopic as relates to the electron microscope. PNH is a disorder involving a unique, excuse me, Liliana, honey, I'm working. PNH is a disorder that involves a unique subset of cells, which is a clone of cells with a mutation that inactivates the glycoprotein anchor, and it prevents complement-mediated. Excuse me, I'm so sorry. I'm so sorry. I have to stop. I have to stop right now because I can't. I'm working. Say hi to the people. All right. You gotta love the lockdown. Anyway. Mom, I love you. I'm working. Anyway, so it's a disorder involving a unique subset of cells or a clone, and there is a mutation that inactivates the GPI anchor and these associated proteins, and this GPI anchor acts as a failsafe, which prevents complement-mediated lysis of red blood cells. So basically think of this as an ID, a self-non-self differentiation badge that tells the immune system whether this is a cell that gets to stay alive or whether this is an other non-self cell that then must be targeted for deletion. So when you're looking for PNH, you need to be looking for certain historical clues. The hemolysis is a big one. Renal disease not attributable to another cause is another one. And when you talk to people with PNH, you look at something called hemoglobinuria. So hemoglobinuria is often confused with hematuria. But hemoglobinuria is a very specific definition of heme pigment in the urine without red blood cells in the urine. These patients or patients who have PNH often present with aplastic bone marrow, so they can have aplastic anemia, or other hematopoietic disorders such as MDS, myelodysplastic disorder. So then the findings of these disorders will also continue to be apparent, be it decreased red blood cells, white blood cells, or platelet counts that are depressed. So this is a schematic of PNH, and this looks similar actually to some of the disorders and other hemolytic processes, so especially such as AHUS and some of the other complement derived and complement mediated pathophysiology of other disorders that result in red cell lysis. So basically complement is constitutively active because of the alternative pathways. It's always ready to chew something up, be that thing a virus, be that thing a bacteria, be that thing any other sort of invader. Unfortunately, these self-non-self differentiation methods, because innate immunity and complement is an older system, the self-non-self differentiation is just not as good as it is an adaptive immunity, and the feedback on the innate immune system is not as sophisticated because it's an all or none almost sort of effect, whereas adaptive immunity, because it goes through the thymus, the antibodies that target self-antigens are usually disabled at a young age, and the clonal B cells that result in them deleted. And then the GPI anchor is the important thing here. So the GPI anchor is that self-non-self badge that tells the immune system that a red cell or a white cell or a circulating cell clone actually is going to be not targeted for deletion. So anyway, so the GPI anchor, this is the complex metabolic badge that then targets, that then prevents the cells from being clonally destroyed. The important thing is there are X-linked chromosomal mutations that result in congenital forms of PNH. The GPI anchor mutation, when it's congenital and not acquired, in a sort of pseudo-neoplastic sort of way, is X-linked dominant. So it takes one mutation in order to display the PNH characteristics. The other proteins that are involved in the circulation and the fielding of the GPI and the fielding of the GPI anchor are CD55 and CD59. So one of the other interesting things we note is when we actually, and we're going to go over why, when we go over either the pathophysiology of PNH, we'll find that for reasons that we'll get into, that PNH is not just a disorder of hemolysis, but that PNH is a thrombophilic condition, which involves coagulation abnormalities. And as I mentioned down there, it's due to complement hyperactivation and hemolysis. So epidemiology, something that I want to make sure that we understand is that this disease is actually a subset of diseases, that involves MAHA and involves red cell destruction, and that it is not just a purely genetic disease, but it is really the marriage of a genetic predisposition. It's the marriage of a genetic predisposition with an environmental, It's the marriage of a genetic predisposition with ongoing somatic mutations that then continue to cause the progression of the disorder in a direction towards greater hemolysis, greater kidney damage, and greater red cell destruction. In other words, it's not a one-hit deal. You may start as a patient who develops PNH with certain mutations that then, with additional acquiring of new mutations, result in the disorder being advanced. So there is a genetic anchor to it, no pun intended, because it's the GPI anchor, but then ongoing hits then make the disorder take up steam of its own and then take off. PNH is rather rare, 16 per 1 million patients. If we reduce that number, it comes out to something like maybe 1 in 80,000. The deficiency in the GPI assembly, which is the anchor protein, can be due to the PIG gene, CD55, CD59, and I'm going to show you the whole pathway. So the bottom line, it's not just one genetic mutation, it's multiple genetic mutations. These mutations are not always germline or universal. As I mentioned to you, that these can be clonal mutations. And clonal mutations mean that either you have one main mutation and then other mutations form in the germline, which is why we say it's a clone, because it's one line of cells that continues to form. Probably the best way to keep it quiet. One line of mutations that then continues to accrue hits, and then that becomes more destructive. The other thing I was going to mention to you is, and I think this is a question that folks are going to ask, is the clone size is absolutely related to not only pathophysiology and damage that then forms because of the increased hemolysis, but there is some evidence that with an increased greater degree of hemolysis, that then that mutation, that mutated clone as it gets bigger can directly lead to a proportional increase in the end organ damage. Meaning the larger of a clone you have, the more hemolysis you have, the more damage you can naturally expect to see in the end organs. And these clones, what they do is they can acquire a growth advantage, which then allows them to proliferate out of control. So PNH is actually near and dear to other diseases that are near and dear to my heart, because I'm almost something of an onconephrologist, or really a hemo-onconephrologist. So PNH has in common with TTP, AHUS, and some autoantibody-mediated causes of C3GN, the idea of endothelial damage and microangiopathic hemolysis. What that means is the red cells tend to pop. The congenital forms that I mentioned are when you have something really strong in the germline affecting the entire GPI anchor. However, the acquired forms are more common, and what it is either there's a genetic mutation that's elaborated on in certain cells, or that there are acquired somatic mutations, much in the way that cancer progresses, that then result in this clone of red cells and other cells that then in time will develop into a larger clone because of the growth advantage, and then will start popping because it doesn't have that self-non-self identification badge. What it is with these diseases is because they both involve lysis, things like AHUS and PNH can look somewhat similar with some important distinctions. One of them actually is my specialty, is renal failure, which tends to be more mild with PNH. So one of the important things and why we're presenting this to the AA-MDS Society is that MDS and aplastic anemia are actually both involved in as clinical associations. Because you have these somatic mutations that form in many cases or that elaborate on underlying genetic susceptibility, you actually have very much the mutation process is the same mutation process that can lead to rogue clones that can then be non-functional, like in aplastic anemia or in myelodysplastic syndrome, that are both non-functional and pre-malignant. And malignant transformation is not unheard of with either of these disorders because they basically are loss of function mutations indicating a high mutation rate within these clones that then at a later time can develop into a full-blown malignancy. That's why I think oncology and nephrology really need to work closely. And that's really been the model where I've been at Cedars, at UCLA, and at UC Irvine, where you have hematology and where you have hematology and you have nephrology working together as a team. So clinical patterns of PNH. Much like other hemolytic disorders, you can have cardiovascular, you can have gastroenterological, you can have neurological and hematological manifestations. And what that means is you have a multi-organ system susceptibility. And this is because the microangiopathic hemolytic anemia can cause damage to the endothelium and can cause damage to the endothelium and can cause actual damage by hemosiderin deposition, as we're going to see in the kidneys and in other organs. And what we really need to see here is that you're going to see three patterns. You're going to see classic PNH, which is, I think, more primary, and this is acquired genetics. And what you see there is you don't necessarily see the mutations that, you know, in the bone marrow where you actually have a more acquired form. You can see PNH in the setting of bone marrow disease. You can see PNH in the setting of bone marrow disease. So what this means is that you have a high genetic background of mutations, that then you have one clone of cells, and this clone of cells then gets disrupted in the way that then forms these deficient GPI anchorless cells that are then popped. And then you can see subclinical PNH without microangiopathic hemolytic anemia. And this is usually the subclinical PNH type, where you have small clones that are not popping as much. So clinical findings, basically, because of the hemolysis, this is where everything follows. You have end-organ dysfunction, you have anemia, so people feel tired, you have thrombosis, and this is a very important part of the PNH equation that we really don't have independent treatment for. So thrombosis probably occurs, as I mentioned, because the endovascular cells, which are the cells that line the arteries and the veins of the body, become damaged. Because they line the arteries and the veins of the body and they get damaged, there are mediators that are released that then cause abnormal clotting. As I've mentioned, the endothelium is in communication with complement and the coagulation cascade. And if the endothelium is damaged and complement is dysfunctional, then what ends up happening is the coagulation cascade is triggered as well, because complement and the coagulation cascade really go hand in hand and talk to each other. So the clinical findings that you see in PNH, as we mentioned, have a lot to do with the dysregulation of complement, which, as I mentioned, is a aggressive, old, almost just devastatingly all or none system where you actually end up having almost mindless killing of anything that's not you. And that's only averted by delay accelerating factor and other factors, factor H, factor I, other factors that actually control the activation of complement around cells, in addition to other cells that are like the GPI anchor on red cells, which are anucleated cells, and which are cells without a nucleus. So this is how the cell lets the body know, well, don't hurt me, I'm a red cell. Okay, so that's why that GPI anchor is so important. And that's why mutations in that GPI anchor are so devastating, because your blood is literally alive. It's just looking for something that's not you. And the part of the blood that isn't this intelligent adaptive antibody response is really going to end up being your innate immune system and your complement system, which just goes at anything that is not you. And when that happens, the blood, the milieu in the blood becomes completely dysregulated. And this is why we see the thrombosis. And the reason I'm going over this and why I think it's important is actually there's a 40% mortality attached to thrombosis. So if people present with thrombosis, there's a really, really high morbidity and mortality from that. That's why I think this is why it's important for you as patients to know that it's an ominous sign. And this is why folks can't miss the diagnosis of PNH, because DVTs and PEs and strokes and heart attacks are very high morbidity and mortality. So now that we sort of talked about the introduction of this rare disease that occurs in 1 out of 80,000 people, or 16 out of 1 million, something like that, where the prominent cardinal signs are end organ dysfunction due to microangiopathic hemolysis and endothelial dysfunction and thrombosis. The real question is, well, how do we diagnose it? Because I think most of the folks here who are patients or loved ones of patients have an idea and know what PNH is. But where I think a lot of folks get lost is doctors often don't take the time or can't take the time to go into depth about how we know what we know. So the first step in diagnosing a rare disease, as somebody who deals with rare diseases all the time and writes about them all the time, is to suspect it. So this is the conversation through the labs that really can be facilitated between you and your doctor, or between physicians, that can help identify this process that's ongoing. So the first step is to demonstrate the disease process. We know what this is. We know this is a failure of non-self recognition because of the elimination of the GPI anchor. We know this for a fact. We know that it's associated with AA and MDS. We know that this is something where you have a history generally of some, if not hematopoietic malignancy, but a pre-malignant condition like MDS or aplastic anemia, and in some cases a full outright malignancy. We know that sometimes this presents with some mild or moderate, not necessarily severe, but mild or moderate chronic kidney disease, and we'll get to the reasons why actually in this section. We know that it's associated with hemoglobinuria as opposed to hematuria, which is basically the finding of heme pigment in the urine without necessarily blood. We know that when people have these symptoms, they generally report feeling tired because of the anemia, and sometimes they have what's called dystonia, or abnormal muscle tone. So those are the symptoms. Now, what are the signs? Well, if someone tells you they have red urine, you immediately think blood in the urine, but what you see is you see a mismatch where you see the heme pigment in the urine analysis, and you can do that because our test in the standard urine analysis looks for heme pigments. But when you look at it under the microscope, you don't see red blood cells. This is called hemosiderin. Hemosiderin is basically the pigment type, and it stains blue. And hemosiderin can actually be seen on your analysis in addition to, the kidney biopsy and with other sort of more advanced testing. You see evidence of chronic kidney disease, which, to be very specific, is basically the kidneys are not filtering at the level they're supposed to be filtering. And then you see the hemolysis, which is the cornerstone in the diagnosis of PNH, as well as other prothrombotic, procoagulant, complement-mediated disorders. And you see elevated reticulocytes, which is the body trying to replace the dead red cells, LDH, lactate dehydrogenase elevations, which are seen because LDH lives in the cells. And you see depleted haptoglobin, because haptoglobin scavenges the heme pigment that's actually swimming in the blood. And we call that microangiopathic hemolytic anemia. keep repeating that term because it's very important that in repeating this term, I mentioned to you that this is the sort of sharp edge of PNH. This is what actually causes the end organ dysfunction, and then later causes the clotting and causes the cells that line the small blood vessels to actually become injured, that leads to further damage in the end organ systems. So the mismatch looks like this. And what you can see here is when you have hemoglobinuria and you can centrifuge it, you should be able to clear out all the red cells because the cells will collect at the bottom. But if you just have hemoglobin that is causing the red color, eliminating the cells by centrifuging them actually will not show you much relief of the redness of the color of the urine. And that's a simple test. And really, every time you see a kidney doctor, if there's a question of blood in the urine or what we call glomerular disease, they should be checking urine, and that urine should either be checked in a lab and looked at under a microscope to tell whether those red cells are simple red cells from the ureter and from the bladder, or are they casts of red cells which are indicative of an immune attack on the kidneys, or if they're just heme pigments. And that's how you're going to get the mismatch in the first place. You're going to get the mismatch by suspecting that that red color is not cellular, that that red color is really related to the pigment. So there's what we call a huge differential diagnosis for why people have blood in the urine or red color or other colors in the urine. There's something called purple urine bag disease. There's a lot of them. But for the purposes of this talk, I'm going to say that cellular red blood cells hematuria is usually dealing with either cancer or inflammation in the kidneys, whereas this type of disorder is very different, where we have acellular pigmenturia or pigment in the urine. And because of that, you suspect that there is something causing leak or damage of that pigment from red blood cells where it usually lives. And that's the definition of hemoglobinuria. If I actually communicate nothing today, I want to communicate that, because the number of folks who misunderstand hematuria versus hemoglobinuria in the medical community is not small. So we have to make a strong distinction, because you will suspect paroxysmal nocturnal hemoglobinuria based on the finding of hemoglobinuria. So it's very important to know what that is. Now, the paroxysmal is important because the PNH attacks tend to occur early in the morning after awakening. So when you get up from sleep, this is usually when people note the change in the urine color. So that's why we call it paroxysmal and nocturnal, because it occurs episodically, and nocturnal because it seems to have a predilection for occurring from awakening in the morning or early morning hours, the night, nocturia. That's what so how do we confirm it? After taking here we go. After taking a good history and a physical, which we always say in medical school is 70% of the diagnosis, is making sure that we take a good history and a good physical. After we've done the elemental blood test, we find some renal failure we can't understand. We find some high blood pressure. We find some blood or blood-like red substance in the urine. Then we have the HAM test. And what the HAM test is a test that looks for absorbance changes due to complement-mediated lysis and acidified serum. In English, that means we take some acid, we throw it in with the serum of the blood, and we see if the red cells lyse or not. That's it. That's all we're supposed to do. So that's the second sort of more confirmatory. We're moving from the direction of, okay, gee, we have this constellation of symptoms and signs, and then we're now moving into the real sort of more confirmatory, demonstrating the pathology. Okay, and the HAM test is the first one. And this test is then firmly and finally confirmed by another assay. So the HAM test is just a simple blood test, and you basically demonstrate that there is something off with the complement system here, or the cells that are in interaction with the complement system, they're just lysing too readily, something that's not right. So this also can be used to demonstrate pathology with a slight tweak in another complement-mediated disorder called syndrome. Now, the flow cytometry test is what we would like to call the gold standard test. So what the flow cytometry test is a test to look for tags or protein tags on cells. And really what you expect to see with the flow cytometry test is the absence of the GPI anchor. Now, we mentioned there's a lot of other proteins that go into making the GPI anchor. It's not just the protein that's missing. Sometimes you have a protein that's missing on the surface of the cell, and the protein is sitting inside the cell because it takes a lot of hands to do a lot of work, a lot of molecular machinery to get a protein folded and correctly chemically modified and then placed on the cell as a marker of self-identity. So if that's missing, it doesn't tell you necessarily where the mutation is, but it tells you there's something wrong with the process that takes the proteins, folds them appropriately, and then attaches them to the cell. Okay, so that's what the flow cytometry is going to show. It's going to show the populations of red cells and other white cells and other cells in the bone marrow line, and it's going to show you if there is what we call a clone. Now, the word clone means a group of cells from a genetically unique ancestor. And if you have, that's why if you have a mutation in that original progenitor or sort of mommy or daddy cell, that mutation keeps getting passed on and sometimes elaborated with more mutations. As I mentioned to you, there is a purely genetic form where the bone marrow is pristine because there are what we call germline or mutations that are inborn in the patient that then result in the GPI anchor not being present. But then there are more cancer-like processes of acquired mutations, which aren't truly cancer, or at least not yet, but they sort of follow that damaged cell model where the cell elaborates different genetic mutations where it starts behaving ways different than the manufacturer intended, if you will. Now, this is why the clones are important. It's because if the clone is of cells that are misbehaving is small, it doesn't tend to cause as much trouble. But as that number goes above 10%, we start to see clinically apparent signs of PNH. And the higher the number, the percent of the clone, the higher the hemolysis levels, the higher possibly chronic kidney damage may become. And this is theoretical. This hasn't necessarily been tested, but that it would make sense that that's a possibility. And sometimes you'll pick up a small PNH clone or subclinical PNH on this flow cytometry. So this test not only tells you that you have a group of cells indeed with the GPI anchor missing, but it also tells you how big it is, and it tells you how much trouble you can expect. So I mentioned to you physician-performed urinalysis. So this is a lost art, and I have a good friend and colleague of mine who teaches at Ochsner School of Medicine in New Orleans, Dr. Velez. And Dr. Velez has made an art of this. And it used to be in the old days that not a single time you go to a nephrologist that somebody won't take a look at your urine under the microscope. And, you know, in some other parts of the world with less availability of kidney biopsies, this is a very important test for diagnosing glomerular inflammation or inflammation in the filtering parts of the kidney. And what you expect to see in PNH is you expect to see what's called hemosiderin, especially if you do a Prussian blue stain, you're able to actually see iron, because heme is a chemical cage that holds an iron molecule inside of it. And you can actually say, hey, there's iron pigment in here. This is not normal. So this actually is what a physician with a proper stain can see with a urine test that actually shows the hemoglobinuria captured in real time. Here. Now, the sensitivity of this test is not fantastic, meaning it isn't present 100% of the time, but this is a cheap and easy way to do it. And if you find it, great. If you don't, then you move on to the other process. If for some reason the flow cytometry is not definitive, if you still have questions, renal biopsies have been done on folks with PNH. And we find that the damage is tubular, meaning it's in sort of the molecular filtering machinery rather than the actual blood vessel filtering system, which draws fluid out of the blood to be filtered. We see what's called sclerosis, focal and global sclerosis, which is basically scarring because of damage. And then we actually see some interesting things. We see urate nephropathy. This is uric acid that then forms crystals and damages the cells. We can see papillary necrosis, or the death of some parts of the kidney, presumptively due to the toxicity from the uric acid, toxicity from the iron pigment, the hemosiderin, and then the actual damage from other mediators that are let out from the red cell exploding. So we see quite a few different pathways, but they all link back to the hemolysis, because that is really the problem. So the PNH, the anemia problem, is directly linked back to the hemolysis. The clone size is directly linked to how much hemolysis you're going to get. And the actual damage in the kidney, and this is what's really interesting here, is also linked to how much hemolysis you're going to get hopefully that's new information for you guys. And like I said, this has not been clinically confirmed in large-scale trials, but it makes a lot of sense. And just like PNH symptoms are worse with larger clones, I would expect kidney damage from PNH to be worse in folks with larger clones. The clones can vary in size, and we mentioned this part. And we mentioned that 10% appears clinically significant. But as I mentioned, the larger the clone, the larger the hemolysis, the larger the effect you're going to expect to see. So now we're going to get into some of the, I think, more fun parts of this talk. We're going to talk about some of the harder to grasp topics about PNH, because PNH has sort of two flavors. And the reason I love this is it actually really mirrors the AHUS and TTP even as clotting disorders. So these clotting complement-mediated disorders, actually, there are forms that are very genetic and are apparent at a very young age. And then there are forms where people either get antibodies in the other diseases, or in this case, get somatic mutations, or mutations that occur once one is full grown and their DNA is already expressed, where the DNA sort of changes due to mutagens or basically substances capable of causing damage or change to the DNA, or due to process of inaccurate or inappropriate cell division that then cause what is called a phenocopy. Basically, it's like a mimic. So you have the pure genetic form, which can be very severe and is dominant because you only need, you just need hemolysis. You need a clone of these cells to grow. But you also have an imitator where you gradually get enough of these small mutations, or you get a mutation in the right place, it starts to act like folks who've had this disease, that was handed down to them from birth. So this is a pattern we see with these disorders, where you can have the bone marrow grow into that pathway of dysfunction that would be coded for by genetic mutations. So it shows you that the human body is an open system, and it's a system that's constantly changing, and that genetics are not a set thing, and that with the wrong inputs or the right wrong inputs, you can actually steer these progenitor cells in a direction where they will dysfunction in a particular way. And it's a reminder to us that, again, that PNH is along that cancer spectrum, where the cells are sort of starting to go rogue, but are not yet rogue enough to be completely out of the control of the body, just rogue enough to not express the right ID badge to cause problems. So this is the GPI pathway. As you can see, that there is progressive glycosylation, or basically different sugars are added to the protein, and that this is a very complex process. And here is the number of genes that you actually have to go through, which are a number of enzymes that keep adding sugars to this anchor that then has to be very specifically produced and properly displayed to avoid damage to the red blood cells. As you can see, there's a lot more than one mutation here. We have several different proteins possible that are involved in the complex underlying biochemistry that then form the scaffolding of this very complex protein. And that's why I sort of mentioned to you that it's not just PIGA, that there is quite a few different antigens that have been identified. And that also explains the somatic mutation process, because if you can get a similar outcome by mutating one of many genes, you have more of a chance of this happening. Whereas if you only have one gene, then maybe the disease would be rarer than it is. And the other thing I wanted to mention is that there is a large variety of mutations identified on the X chromosome, as we mentioned, and then in chromosome 22, and several different groups of scientists have actually compiled roughly about 16 genes involved in this process. So that's why I think one of the other things that folks are working on is genetic analysis. And I'm aware that one group up in Oakland, Mayshon Labs, is working on PNH genetics as well, which is very exciting. And I think something widely practiced overseas in Europe. And I think for American medicine to truly catch up, unfortunately we're behind, we have to get in the habit of looking for genetic causes for things, because this expands our knowledge, and it's also uniquely valuable in cases of transplantation or in donation, and particularly in genetically sourced causes, genetically sourced cases, where this is something that's coming in sort of parent to child transmission. Even when we look at acquired forms of PNH, it's still valuable to know how often genes get damaged and which genes get damaged, because DNA is not all created equal. Certain segments are more prone to damage and more prone to expression or being silenced from being expressed, depending just on the geography and the architecture of the DNA molecule, which is three-dimensional and very complex actually in structure. It's not just a simple double helix, it's a double helix with proteins around it, and then it's folded in particular ways. So this is the interesting stuff that's going to really power the engine of discovery for tomorrow. So as I mentioned to you, PNH is an evolving process. Either there's such a strong founder mutation that's coming from birth that then it gives this phenotype or this, what's the word, presentation or look, right off the bat. Or you can start small with something in the GPI synthesis pathway. And then another one can just happen to occur, and then another one, until you have increasing numbers of clones that are liable to not express the GPI anchor. And this can be occurring in a background of mutation in the bone marrow, which then could push the progenitor cells, or the cells that are then forming into white cell lines, platelet lines, and red blood cell lines down a cancerous or myelodysplastic path. Interesting. So I think I just wanted to cover the names of a few of them and mention to you that I think everybody, if they have access to it through their insurance, should definitely consider getting genetic testing to find out what their founder mutations and the other mutations in the pathway are, if for no other reason than to know and contribute to the knowledge base that will allow the developing of targeted therapeutics. And then we mentioned thrombosis, and I sort of mentioned offhand that this happens because there's crosstalk between the coagulation cascade and between the complement cascade. Now, to be even more specific, the reason is because plasminogen and thrombin, which are involved in the clotting cascade, actually have inputs in the complement cascade. And this is important because if you think about it, a lot of bacterial infections actually cause clotting issues and can cause rampant clotting, something called DIC. And this occurs because the whole blood is sort of upset at the presence of an invader. And then the body sort of goes on a fight or flight mode. And then these proteins, like complement and coagulation proteins, are overexpressed. Because the body is not very good at telling what's a bacterial stress versus a large, saber-toothed tiger that's getting ready to attack you. It really has a very similar stress response. So when you have a stressor or an infection, your blood is more likely to clot and more likely to react to attack and defeat and destroy whatever thing that is in you that doesn't belong there. And specifically, I did mention to you it's plasminogen and fibrin that are the crux of why you have clotting occurring. Now, the important thing, I also mentioned endothelial dysfunction. Let me mention to you what that is. Endothelial dysfunction just means the cells that are regulating these processes on the side walls of the blood vessels are damaged. They are not happy with the red cells popping. Then the body's designed so what is in cells should really stay in cells, and what's outside of cells should really stay outside of cells. When what's inside of cells comes out, it's a noxious stimuli to the endothelial cells. And when they're damaged, things like proper nitric oxide production, things like blood flow are all compromised. Oxygen delivery is compromised, and that results in even more noxious stimuli. So because you have damage to the very highways of supply in the body, all these toxic mediators build up. And because these toxic mediators build up, the blood starts behaving in strange and unusual ways, namely clotting. And again, just so you're familiar with the names, it's thrombin and plasminogen. And the way this happens, it occurs in very much the same way across multiple disorders. And it occurs this way in, when you have red cell lysis due to the lack of a nutritional vitamin like vitamin B12, you have endovascular damage when this occurs with certain bacterial products that can mess up the complement system, like hemolytic uremic syndrome, to be differentiated from atypical hemolytic uremic syndrome. You have some of it with other disorders like TTP, and you have some with AHUS, as I mentioned. The bottom line is what really unites all these disorders is the lysis of red blood cells. And it's really those red blood cells that are popping that is really why you have all the symptoms and the disorders and the problems that one has in this condition. So basically, this is a natural place to say, really put our finger on this is really what's wrong. It's the complement system. And this is why so many of the therapeutics surrounding PNH have to do with curtailing the activity of the complement system in a number of creative ways. Because the complement system has two sort of Achilles heels. It has three entryways, two control points, the C3 and C5 convertase, which is like the amplification factory, and then one end effector, which is basically a bunch of these complement proteins getting together, forming a tube, getting into the red blood cell and popping it. So in order to really disrupt this process, you really have to zero in and with laser-like focus, take out the amplification points. And we will discuss more of that with therapeutics. And there's therapeutics. So basically PNH, when we first discovered it, or what it is, we mainly our hematological colleagues try to do a couple of things. One is they try to control the symptoms. We know everybody gets tired, so there's a lot of blood transfusions. And then there was also the option of bone marrow transplant or stem cell transplant. And while stem cell transplant sometimes worked, there sometimes was ongoing transfusion dependence, and people who got too many red blood cell transfusions developed iron overload and then could develop liver damage and could develop deposition of iron all over the body. And you know, one of the main markers for well-being in PNH is how often people get blood transfusions. If people get a lot of blood transfusions, that usually means the disease is either severe or not well controlled. And of course, because there is hemolysis, you're already dealing with iron overload. So by giving more blood cells, which have more iron, you really can exacerbate this to a critical point. So basically, a lot of smart folks got together and said, well, since complement is really what is involved in lysing the GPI deficient clones, which have a growth advantage, these are the clones that cause PNH ostensibly, we should really focus on blocking complement in order to prevent hemolysis and anemia, damage to the endothelial cells or endothelial dysfunction, and then clotting or thrombosis, and then pigment-related acute kidney injury. The rationale basically is that by blocking complement, you are able to prevent the red cell lysis, prevent the iron overload and deposition, prevent the chronic damage to the organs such as the kidneys because of hemosiderin deposition, and improve quality of life, and of course not exacerbate the whole problem by having to give so many red blood cells, which obviously can cause more iron overload. There's a slight risk of infection with them. There's hospitalization or need to be in a transfusion center. So all of those things really contributed to the difficulty of the life of somebody with PNH. So the seminal studies, the original studies, involved C5 blockade. The molecule is eculizumab. And of course, I want to make sure that I go over things in a way that is completely neutral. So eculizumab was simply just the first. The brand name is Solaris, but the main thing that this drug does is it prevents the activation of the complement system by targeting the second control point, which is the C5 convertase, which actually causes the final amplification of complement right before the formation of the membrane attack complex, which is the pore that, like a straw, literally just goes in the membrane of a cell and lyses it. There are a number of other targets that have been considered. So this is the mechanism of action, or the MOA, of eculizumab, and it's usually given every 2 weeks. And there's a new agent that's available every 8 weeks. So this is eculizumab. As you can see, the dosing is different. Actually, it's lower than the dosing for anyone who's familiar with some of the other more intensive lysis diseases like AHUS. And then this is the loading dose for ravulizumab. And this is from a new review in Therapeutic Advances in Hematology. And this is actually a very popular slide in other talks. One of the things that's important is monitoring C5a levels. Once you give this drug, you have to keep in mind that it's not necessarily a set schedule. Sometimes you have to give an extra dose if folks are still showing breakthrough hemolysis, meaning that the red cells are still lysing, because remember, that's really the business end of the disease. The other thing that you have to keep in mind is that dose can be adjusted. It's not written in stone because we are starting off at the lower dose, particularly of the drug that's given every 2 weeks. The other thing to sort of mention is that the really good clinicians with experience are the ones who are going to check for complement depletion, meaning to make sure that the complement levels are actually responding to therapy and are sort of bottomed out. So we have grades of responses. There's anything from a complete response to no response. And that's why C5 blockade, as interesting as it was and as it's sort of being elaborated and different molecules are being developed for it, there was also a question about other targets besides C5 blockade. And this is really occurring because you see this breakthrough. You put people on therapy, you check the C5 convertase levels, the C5a is minimized, you actually have complete suppression of complement elaboration at the second control point. But remember, this is what we call distal blockade, or blockade down a couple of steps from where the process begins. Sort of looking at a schema of how complement works, there is also what we call the C3 convertase, and we call that proximal blockade. That is blockade nearer to the origination point where complement starts to amplify and explode before it forms these little deadly daggers that go into cells and then pop them. So C3 blockade is now an established therapeutic strategy for PNH. There are multiple trials that folks are looking into. I know that there have been encouraging results, and this comes from APL2 and then another drug called Comstatin, which is similar. And really the other interesting thing that people have noticed in PNH, as opposed to other diseases that respond to downstream blocking, is blocking the process upstream actually really helps curb lysis of blood cells outside the blood vessels. We call it extravascular hemolysis. So bone marrow transplant may still be necessary. It would definitely is up to the discretion of the hematologist. Certainly something I as a nephrologist would not necessarily advocate offhand, but remember, there are complete responses and there are non-responders. And even with C5 blockade, C3 blockade, and now something else called factor D blockade that people are looking into, that a hematologist may decide that this is the path to take. One way to sort of look at this disease is that this disease is midway between normal cells or cells with a slight abnormality to cells that are full-blown malignant. So you always have to keep in mind that there is always the risk of the development of either malignancy or bone marrow failure, because this disease is just an elaboration of the ongoing cycle of genetic mutations in the cells that then make the red blood cells the white blood cells, particularly in this case in the cells that make the red blood cells. So one thing that is very important whenever we talk about complement blockade, certainly C5 blockade of all shades, and still according to the FDA, we have to be worried about it with C3 blockade, though the data is being elaborated on this. There is a risk of infection with encapsulated organisms. This is particularly true of Neisseria meningitidis, otherwise known as the bacteria that causes meningitis. So it is worrisome. In the trials of complement blockade, we usually got an incidence of 1 to 2%. Some of the creative things folks have done is they vaccinate it right away, and then if there's a real urgency with certain diseases, is that they'll put people on antibiotics to prevent the bacterial infection from occurring. Currently, what's actually required by the FDA is vaccination and waiting 2 weeks before initiating the drug, with the thought that that's when the more stronger antibodies will be available. Those stronger antibodies are called IgG. So right now, what I do is that I certainly vaccinate anybody who I think is a candidate for complement blockade. I will start them on antibiotic therapy with a penicillin or something called a macrolide if they're allergic to penicillin. And then personal practice is that I actually make sure they're vaccinated for all other encapsulated organisms. Because really, when you take out complement, folks with complement depletion function like they don't have a spleen. So those folks have particular susceptibilities to certain bacteria. And so something obviously your doctor should be able to look into and help you with if they have any experience with complement blockade. Thrombosis for now should be treated. So the treatment for PNH should not take away from using anticoagulation in order to deal with thrombosis, because at this point, even though theoretically it would help, we don't have evidence that it basically completely eliminates or mitigates the risk of thrombosis. So many people will be on complement blockade and anticoagulation. So this is something that we see in our PNH patients. And there is a number of new trials that are occurring. Most notably C3 blockade, which has at least a couple of agents that folks are looking at, and then more long-acting C5 blocking agents. And of course, factor D blockade. And of course, there's lots of other small molecules that are being tested in the various phases of the FDA approval process. The furthest along are C3 blockade and long-acting C5 blockade. And of course, up there's factor B, so it's a phase 2 working on that as well. So basically, they're trying to cover the whole gambit of complement blockade from very early and very proximal, close to the beginning in the process, all the way to the very bottom in the C5 level, where it's almost midway, right before the formation of the damaging proteins that then pop the cells. And this is sort of a schematic of various different drugs that are being developed in order to combat complement blockade, in order to block complement and combat the formation of out of control complement proteins that then damage the red cells. And as I mentioned to you, you can ask and look into factor B and factor D, C3 and C5, and there's multiple different compounds or molecules that are being looked at every stage of complement in order to make sure that we see if one has an advantage over the other, or if one is more useful in certain types of patients or certain types of complement-mediated diseases than the other. And future directions basically involve looking at every single protein along the whole pathway and seeing, if blocking that will have a game-changing effect on the condition or not. Whenever we start in pharma, whenever we break into a pathway, generally with time, folks will elaborate different molecules that can affect all the different proteins, and then we'll see if one is better than the other, or if one confers an advantage in a situation than the other. And of course, safety is something that is monitored to be able to see, well, maybe this drug can be given orally, maybe this drug has less of an infection risk, maybe this drug is more effective in this versus the other sort of condition. So there's a lot of hope, and there's a lot to be hopeful for. And I think one of the things that I'm interested in is APL2, which is a compstatin derivative, actually. Is a compstatin-like compound. Compstatin, I believe, is a European brand, but here in the States, APL2 is sort of our compstatin. And the bottom line that I wanted to mention to all of you guys is that with time and with cooperation from the advocacy groups and with clinical trial enrollment, it'll be really the patients, you guys, and your help and your willingness to try new agents and moving the clinical trials forward that will yield the breakthroughs that we need in order to keep people off of blood transfusions with a minimum of iron deposition, with a minimum of damage to the end organs because of the disruption of blood flow. And that will make PNH a very manageable condition, even with things like oral medications potentially, or infusions that are given once every couple of months instead of every couple of weeks, that will improve quality of life definitively, not just from eliminating blood transfusions, but from eliminating frequent trips to the infusion center. And that's all I have, and thank you guys for your patience and understanding earlier. Lovely day.
Thank you so much, Dr. Hanna. We do have a few questions, if you don't mind.
Of course.
All right, so I know we're getting close on time, so I'm going to try and get through them real quick.
I'm good. I'm willing to.
Okay.
I'm here.
Well, and I think I speak for everyone. We all did enjoy getting to meet the future doctor in your
Liliana,
house.
yes, I already have her pegged, unfortunately.
This is great. Well, she was charming. But one of the questions submitted is, this patient does not have hemolysis, has no hemolysis with a low PNH clone size. They do take cyclosporine. What might be a greater agent in chronic kidney disease?
So cyclosporin has some definite issues in that as the levels go high, it's capable of independent kidney toxicity. I think that really it depends on the clone size and how sure we are that there is a need for complement blockade. Because if the clone size is very small, it would depend on, is there a high degree of anemia, or is there evidence of tissue deposition of iron that's causing damage? I would be a little nervous about advocating for complement blockade in extremely small sizes of clones, because as I mentioned, complement blockade is dangerous. I think it's a little unorthodox to use cyclosporin though, but there are other agents like mycophenolate mofetil, but that's unstudied. There is voclosporin that's coming out that's a similar sort of mechanism of action, but again, has not been studied. So right now, I think that question, the patient in question, is a little bit on uncharted territory, because if you're treating a very small clone size below 10%, then you're really out of the guidelines, sort of. But if maybe it's an 11% clone or a tiny, barely a clone that's sort of writing that 10, 11% number, then it would be good for the patient in question to speak to their physician, evaluate the pros and cons of complement blockade, and see that with all the risks that I mentioned, it would be something that they would consider, be that C5 blockade, short-acting, long-acting, or even C3 blockade, if there's a possibility for them to enroll in the trial or get the new drug.
Thank you, Dr. Hanna. If my PNH is well managed with Ultomiris infusions, am I likely to get chronic kidney disease? If so, could the treatment for chronic kidney disease cause problems with the PNH treatment?
So really, the treatment for chronic kidney disease is very interesting. Chronic kidney disease, and being a nephrologist, is one of those situations where you really must make a diagnosis in order to prevent progression. Unfortunately, with this situation, we have to be sure that it's the PNH causing the chronic kidney disease, because someone could have diabetes, high blood pressure, and PNH, and the chronic kidney disease could be from the diabetes and the high blood pressure. If you are on Ultomiris, you have basically shut down complement, and unless you're having breakthrough hemolysis, the risk of pigment-mediated kidney injury has gone to almost zero. Okay, so if it's effective and it's well controlled, you don't really have a risk of chronic kidney disease from that. There are chronic kidney disease risks from other things, including even aging. Simple aging, every year over 40, you lose about 1% of your kidney function. And unfortunately, it's sort of like your filter wearing out with time. Kidneys do not last forever, unfortunately. And the treatment for chronic kidney disease is generally, if there's high blood pressure control, with agents called renin-angiotensin-aldosterone blockers, or RAS blockers. And that should not really have much of an effect on Ultomiris at all, because metabolism is different and the mechanism of action is different. So I think that you don't have to worry about PNH causing CKD, chronic kidney disease, in this regard. However, CKD can be due to other conditions, and the medications to treat it are generally not going to interfere with PNH treatment.
Thank you. And our last question is, could surgery or pregnancy increase the possibility of kidney disease?
That's a great question, and something I get often. Pregnancy can cause a number on kidney disease and PNH in a number of ways. So pregnancy can activate the complement system. So if you have the GPI less clone, then it's probably more likely to get lysed. Of course, there are no randomized double-blind controlled studies that demonstrate this, but pathophysiologically, or looking at the mechanism, certainly seems to make sense. As far as other ways that kidneys are actually particularly taxed in pregnancy, and because the kidneys are particularly taxed in pregnancy, unfortunately, being pregnant is bad for the kidneys in and of itself. So it can sort of pull a double whammy here. From one side, it can actually hurt the kidneys because of the hyperfiltration, or the kidney is going into overdrive to support the pregnancy, and it can actually directly affect the PNH as well.
Thank you so much, Dr. Hanna. We did have one last entry. This is our very last question, then we'll sign off. But the question, and I think it's a great one, is, can kidney damage be reversed?
Of course. So having worked at Cedars-Sinai and at UCLA, I have had the pleasure of meeting folks who make a lot of money, more money than I do, people who are CEOs of companies and celebrities and other folks. And, you know, I've always told them that acute or short-term catastrophic damage to the kidneys can be reversed if the cause is identified and if it's autoimmune and if that is completely just shut down. But if people have had ongoing damage for some years, even though the kidneys has a particular self-regenerating capacity, it is not as great as that of the liver, which can actually grow back when areas are damaged. When kidneys are damaged in spots and patchy areas that don't take out a whole filtering unit called a nephron, yes, the kidney is able to rebuild. But if the kidneys are damaged in such a way that entire filtering units are taken out, those cannot be recreated. So to answer your question is, long-term kidney disease is likely not going to be reversible. Short-term catastrophic kidney disease can be repaired through the kidney's regenerative capacity, but there's almost always a loss of function because some filtering units go. Now, that being said, the numbers may not reflect that. The numbers may look good because the kidneys have a lot of reserve, but you know, every time there's kidney damage in a high capacity, some kidney filtration is actually lost. Because some filtering units are lost. Yeah.
Thank you for your thorough answer. I appreciate that. And thank you also for sharing your time and expertise with us today.
Thank you.
For folks watching, if you'd like to watch this again, it'll be available on our website in 2 to 3 business days, and we will send you an email letting you know when it's available. If we didn't get to your question or you think of something else, do send us an email. You can either send us an email to help, HELP, @aamds.org. You can call our helpline at 1-800-747-2820 and press extension 2. Or we are happy to answer your questions on Facebook and on our Facebook page. So you can send us a question there, and we're happy to get to that. This concludes today's webinar. Thank you, Dr. Hanna, and thank you to Liliana. We really appreciate having you today.
Thank you all. Have a wonderful day.
Yeah, thanks, everyone. Bye.